Access in Medicine and the Docs with Disabilities initiative invite you to learn about accommodations for clinical skills exams. In this video, we'll explore how to create more accessible clinical skills assessments. We'll begin by defining common terms and breaking down the key components of clinical skills exams. We'll then discuss what to consider when determining appropriate accommodations, provide examples of reasonable accommodations, and highlight universal design strategies that can improve access for all learners. Some of the terms used in clinical skills exams may be new to you, so let's begin by reviewing a few common terms and definitions. OSCE is an acronym for Objective Structured Clinical Examination and is one of the most common formats used to assess clinical skills. A standardized patient, sometimes called an SP, is an individual trained to portray a patient in a consistent manner during an OSCE. The encounter is standardized so that each student interacts with the same clinical scenario and is assessed under comparable conditions. A mannequin is a model of the human body used in medical simulation. Mannequins can range from simple task trainers to high-fidelity simulators that replicate physiologic responses and clinical findings. A door chart provides the information a student reviews before beginning an OSCE encounter. Depending on the assessment, it may include instructions, elements of the patient's history or medical record, laboratory or test results, or other information needed to complete the encounter. Finally, a SOAP note is a common format for documenting a clinical encounter. SOAP stands for Subjective, Objective, Assessment, and Plan. In a clinical skills exam, the SOAP note may be completed after the patient encounter and serves as the documentation portion of the assessment. An OSCE is an assessment used to evaluate a student's clinical and patient care skills. Depending on the exam, students may interact with a standardized patient or mannequin, or they may be asked to work with other clinical information, such as radiographs, laboratory results, or diagnostic findings. The objective and structured elements of an OSCE come from creating consistent assessment conditions. Students are presented with the same or comparable clinical tasks and are evaluated using established criteria. Importantly, consistency does not mean that every learner must complete the assessment in exactly the same way. We can preserve the integrity of the assessment while allowing for differences in how learners access or demonstrate the skills being measured. OSCEs may include multiple stations, with students completing a specific clinical task within a set amount of time at each station. The structure of individual stations can vary. A student might review clinical information, interact with a standardized patient, perform a physical examination or procedure, interpret diagnostic findings, or document the encounter. OSCEs may also serve different purposes. Formative OSCEs are generally used to assess a student's developing skills and provide feedback. Summative OSCEs are used to formally evaluate whether a student has achieved the expected skills or competencies. Understanding both the structure and purpose of the OSCE is important when considering accommodations, because accommodations should provide access to the assessment without changing the skills or competencies the exam is designed to measure. OSCEs often include three discrete components: a door chart, a patient encounter, and a post-encounter task. Each component may have its own time limit. The door chart is the reading portion that occurs before the patient encounter. During this time, the student is provided with initial information about the patient they are about to see, along with instructions about what they are expected to do during the encounter. The patient encounter is the portion of the assessment in which the student interacts with the standardized patient. Depending on the instructions, the student may take a history, ask questions, perform portions of a physical examination, or complete other clinical tasks. Following the patient encounter, the student may complete a post-encounter task. This might involve writing a SOAP note or case note, or giving an oral presentation to a faculty member summarizing the encounter. It is important to recognize these as discrete components of the OSCE because each component requires different skills and presents different potential access barriers. When considering accommodations, we need to understand not only the OSCE as a whole, but what the student is being asked to do during each part of the assessment. When considering accommodations for an OSCE, it is important to understand both what is being assessed and how it is being measured. The disability resource professional should engage in an interactive process with appropriate faculty and staff to understand the knowledge, skills, or competencies the assessment is intended to evaluate and how each component of the OSCE measures them. An important part of this process is distinguishing between what is essential to the assessment and what is simply a product of the assessment design. For example, if a task is timed, is completing that task within that specific amount of time an essential component of the competency being assessed? Or is the time limit simply how the assessment has traditionally been administered? The DRP can then consider how the student's functional limitations interact with each component of the assessment and determine what accommodations may provide equitable access without altering what the assessment is intended to measure. These conversations can also identify opportunities for universal design. In some cases, changes to the way an OSCE is designed or administered can reduce unnecessary barriers for all students while preserving the knowledge and skills the assessment is intended to evaluate. Accommodations for an OSCE will vary depending on the student's functional limitations, the structure of the assessment, and the skills or competencies being measured. Examples might include a reduced distraction environment for reviewing door charts or completing documentation, additional time for specific reading, documentation, or other components of the OSCE, and assistive technology, such as speech-to-text or dictation software. Accommodations might also include adjustable exam tables, desks or chairs, accessible electronic health records or testing materials, or breaks between OSCE stations. Importantly, accommodations do not necessarily need to apply to the entire OSCE. Because an OSCE includes discrete components, an accommodation may be appropriate for one portion of the assessment but not another. For example, a student may need additional time to review a door chart or complete a written note without needing additional time for the patient encounter itself. Universal design originated in architecture as an approach to creating environments that are usable by the widest range of people. These principles have since been applied to education through Universal Design for Learning, or UDL, which focuses on reducing barriers and designing learning experiences that account for learner variability from the outset. A related concept, Universal Design of Assessment, or UDA, applies these principles specifically to how we assess learners. UDA asks us to consider whether features of an assessment create barriers that are unrelated to the knowledge, skills, or competencies we actually intend to measure. For clinical skills assessments, this distinction is particularly important. By identifying and reducing unnecessary barriers in the design and administration of an OSCE, we can make the assessment accessible to a broader range of learners while preserving the integrity of what is being assessed. Universal design does not replace individual accommodations. Rather, good assessment design creates a more accessible foundation, with individualized accommodations addressing barriers that remain. There are several ways to incorporate universal design principles into clinical skills assessments. For example, door charts can be provided in accessible formats. Depending on what the assessment is intended to measure, information might be available in both written and audio formats or through technology that supports different methods of access. Door chart stations can also be height adjustable so that students can review materials from a seated or standing position. The physical environment should also be considered. Ideally, accessibility is built into every exam room rather than limited to a single designated accessible room. Rooms can include height adjustable or lowered medical equipment, accessible exam tables, and equipment positioned so that it can be reached and used by learners with a range of mobility and access needs. The structure of the OSCE can also reduce unnecessary barriers. Rather than requiring students to rotate from room to room, standardized patients could rotate while students remain in an assigned room. This can reduce mobility, fatigue, or sensory barriers without changing the clinical skills being assessed. Accessibility can also be incorporated into the technology used during the assessment, including electronic health records and compatibility with assistive technology. Finally, consider the post-encounter task. If handwriting or typing is not itself a skill being assessed, students might be able to use different methods to document the encounter, including typing, dictation, or speech-to-text technology. The goal is to examine each component of the OSCE and ask, is the way we have designed this task necessary to measure the intended skill? Or could we provide greater access without changing what we are assessing? We've covered a number of considerations for making clinical skills assessments more accessible, but putting these principles into practice can sometimes be challenging. To help operationalize this process, Meeks and colleagues developed a 12-step decision-making framework for identifying and addressing access barriers in OSCEs. The framework begins by breaking the OSCE into its discrete components and identifying the specific knowledge, skills, or competencies being assessed within each component. From there, the disability resource professional considers the student's functional limitations, identifies where access breaks down, and distinguishes the construct being assessed from the format being used to assess it. The framework then asks whether universal design can reduce or remove the barrier before identifying an individualized accommodation. It also includes consulting available evidence and expertise, considering feasibility, and confirming that the accommodation preserves the intended construct and validity of the assessment. Finally, the process includes documenting the rationale and evaluating whether the accommodation worked as intended, using what was learned to improve future clinical skills assessments. The framework provides a systematic approach that shifts the question from "can this OSCE be accommodated?" to "where's the barrier? What are we actually assessing? And how can we provide access while preserving the competency being measured?" This video is a product of the Docs with Disabilities Initiative's Access in Medicine program in partnership with the University of Michigan Center for Disability Health and Wellness. The contents of this video were developed under a grant from the National Institute on Disability, Independent Living, and Rehabilitation Research. NIDLR Grant Number 90RTHF0005. NIDLR is a center within the Administration for Community Living, Department of Health and Human Services. The contents of this video do not necessarily represent the policy of NIDLR, Administration for Community Living, or Health and Human Services, and you should not assume endorsement by the federal government. This video is a product of the Docs with Disabilities Initiative and their Access in Medicine program. For additional resources and information about the Docs with Disabilities Initiative, please visit the Docs with Disabilities Initiative website or follow us on YouTube, Twitter, Instagram, and LinkedIn.